All right, everyone, welcome. If you're gearing up for the NEAT PG, you know that imaging questions can make or break your score. So today, we're going to do a super fast, high-energy review of the surgical imaging concepts you absolutely have to know. Let's get you ready for that exam. Here's the deal. We've got 6 classic, high-yield questions coming your way. The idea is to get you thinking on your feet, just like in the real exam. We're going to try and do this in about 5 minutes, so let's not waste any time. Okay, first up, we have a topic that examiners absolutely love to ask about: contrast agents and patient safety. You know, this is the kind of bread and butter stuff you need to know backwards and forwards. So, first question. Picture this. You've got a patient with really bad kidneys, severe renal failure, and you're thinking about ordering an MRI with contrast. What's the #1 risk you have to worry about? There's a very specific, very nasty complication tied to gadolinium in this exact scenario. What's your call? And the answer is C, nephrogenic systemic fibrosis, or NSF. So here's the key takeaway, the thing you have to burn into your brain. The equation is simple. Gadolinium plus severe renal failure can lead to NSF. It's a truly awful condition that causes fibrosis everywhere. For your exam, just lock in this connection. If you see an eGFR less than 30, using gadolinium is a massive, massive red flag. All right, moving on to our second topic, radiation safety. It's not just about knowing which scan to order, right? You also have to have a sense of the risks involved, and that means understanding radiation doses. So I want you to really think about the scale here. We're talking about one single imaging scan that zaps a patient with the same amount of radiation as 500 chest x-rays. That's a huge dose. Which of these scans is the culprit? Yeah, 500. That's not just a number on a page, you know. In radiology, that represents a really significant radiation burden. It's something we have to justify clinically every single time we order it. And the answer is the CT abdomen/pelvis. This slide shows you why perfectly. Look at that jump. A chest x-ray is less than 0.1 millisieverts, while the CT is over 10. The reason is pretty straightforward, really. It's because of volumetric acquisition. The CT scanner is taking hundreds and hundreds of tiny slices through a big chunk of your body, and all that radiation just adds up. Okay, let's shift gears and head to the emergency room. You know, trauma imaging is a whole different ballgame. It's high stakes, high pressure, and one of the most critical jobs you have is clearing the cervical spine. So here is your classic trauma scenario. You've got a patient, they're unconscious, unstable, polytrauma. You absolutely have to rule out a C-spine fracture, and you need to do it fast and with certainty. What's the one scan you're going to order? The one and only definitive answer here is a CT of the cervical spine, no question. And this scan shows you exactly why CT is the king in this situation. Look, in an unconscious patient, a plain X-ray just isn't good enough. It can easily miss tiny fractures, but CT, it's incredibly fast, and it gives you this gorgeous, detailed look at all the bones. It's the undisputed first choice, period. Next up, let's do a rapid-fire round on the acute abdomen. We're going to look at 2 super common presentations you'll see all the time, but each one needs a different first-line imaging choice. Okay, case 1. You hear this presentation. Older patient, they've got a fever and that classic left iliac fossa pain. A diagnosis should be popping right into your head: acute diverticulitis. So what's the best scan to confirm it and make sure nothing else is going on? Yep, you got it. The correct choice is a CT of the abdomen with contrast. CT is just made for this. If you look at this scan, you can see those classic signs. The bowel wall is all thickened up, and you see that hazy, dirty-looking fat around the colon. That's the textbook paracolic fat stranding. Not only does this confirm your diagnosis, but, and this is crucial, it lets you spot dangerous complications, like an abscess. All right, boom, next patient. We're moving from the left side of the abdomen over to the right. This person has right upper quadrant pain, and you're thinking it's an angry gallbladder, acute cholecystitis. Different spot, different scan. What's your first choice? For suspected gallbladder problems, your first thought, your go-to, should always be an abdominal ultrasound. And the reason is simple. Ultrasound is fast, there's no radiation, and it's fantastic at showing you the key signs. You're looking for stones, of course, a thickened gallbladder wall, and some fluid around it. And the real clincher is that sonographic Murphy sign, when you press right over the gallbladder with the probe and the patient hits the roof. That's your diagnosis.
All right, for our last question, let's talk about a really common challenge. How do you find a serious infection before you can even see it on a regular x-ray?
Okay, listen up, because this is a classic exam trap. You have a kid with a fever and leg pain, you're thinking bone infection, but the x-ray comes back normal. This happens all the time in early osteomyelitis because the x-ray just can't see the infection yet. So what do you order next to find it?
The most sensitive tool you have in your toolbox for this is, without a doubt, an MRI. If you remember just one thing from this question, let it be this. MRI sees the inflammation long before the x-ray shows bone destruction. It's incredibly sensitive to that early swelling in the bone marrow and soft tissue, sometimes weeks before you'd ever see a change on a plain film. All right, let's do a super quick lightning recap. 1. Gadolinium plus severe renal failure equals a risk of NSF. 2. A CT abdomen/pelvis has the radiation of about 500 chest x-rays. 3. Unconscious trauma patient with a possible neck injury, it's always a CT. 4. Left lower quadrant pain, think diverticulitis, order a CT. 5. Right upper quadrant pain, then cholecystitis, get an ultrasound. And 6. For early osteomyelitis with a normal x-ray, MRI is your best friend. And just like that, you've crushed 6 incredibly high-yield topics. Keep this momentum going, keep reviewing these core ideas, and you are going to be in great shape for your exam. Now, what do you say? Ready for the next case?